Good morning. It's very early in the morning. So in the next 10 to 15 minutes, we'll go with a live case directly from the operating room from Hygeia Hospital. An 84-year-old male patient with ischemic cardiomyopathy, CABG 1988, renal insufficiency, under steroids for rheumatic polymyalgia, logistic Euro score 25, STS score 8%, really symptomatic with heart failure symptoms, NIHA class 3, and severe functional MR with orifice area of 20 millimeters and more, and ejection fraction 20%. The patient was randomized in a RESHAPE trial and in the device group. So we decided to proceed to So this is Dr. Sparias, Dr. Harapas, and at the echo is Dr. Christocheris. When we start the procedure, we always do a screening of the valve once again. As you can see, the ejection fraction is very low in this patient. There is no prolapse or a degenerative component. With the color Doppler, we have a clue where we will guide the clipping. When we have a functional mark, we usually go at the A2, P2 scallop with 1 or 2 clips, whatever is needed. So we begin the screening of the patient. I will go on. Puncture of a femoral vein.
Κώστας, πάμε λίγο πιο γρήγορα σε αυτά.
Ναι, yeah. I will go. Surgeon's view for the mitral valve. Let me go further. This is the MR. You can see that we have a central jet from the A2 P2 scallop, the tethered leaflets of the valve. It's important when we have the patient under sedation, we have to raise a little bit the blood pressure in order to be able to see the regurgitation. And sometimes at first we don't see MR, and we start to think if the patient has MR, and then when we raise the blood pressure, and here's the regurgitation. So we go with an SLO catheter towards the superior vena cava, and then with the echo guidance, we start going down to the atrial septum, and we choose a biplane view of short axis view and bicaval view. Here you can see at the superior vena cava the SLO catheter, and we want to go down to the fossa ovalis, to the thin part of the atrial septum. We use a 3D image as well. Here is the fossa ovalis. It has a dropout artifact. This is how we know the correct position. We always put the aortic valve on our right in order to know where is the anterior and posterior, and we need to guide the interventionist. And then we go for a transeptal puncture. We need to be high and posterior. If we don't like the position, then we can go up again in the superior vena cava and go down to the septum again. So after the transeptal puncture, we start preparing the steerable guide catheter and the clip delivery system, it's important not to have any bubbles of air into the system. And this is crucial for the operation. After the sachet, of course, we put an extra stiff wire at the pulmonary vein, and we have to be careful not to go into the atrial appendage. And then with the steerable guide catheter, we go through the femoral vein up to the right atrium. Sometimes it's difficult to insert the guide. We always do a dilatation with an 18 French dilator and sheath before going with the 24 sheath of the steerable guide catheter. And here you can see the guide catheter going up from the inferior vena cava towards the right atrium.
Κώστα πιο γρήγορα εδώ.
So here you can see the guide catheters into the left atrium. We remove the dilator. We stabilize the guide catheter on the table with a stabilator, and then we proceed with the clip delivery system, where you can see here that the clip is coming out of the guide into the left atrium. And here is very crucial for the echo guide to tell us if we touch the posterior wall of the left atrium or the Coumadin ridge. We don't want to do any harm at the wall of the left atrium. And then we start to flex and lean towards the mitral valve. Here you can see the Coumadin ridge, and then we are below. We pull and flex at the same time until we are above the mitral valve. And we go down, always with biplane views in order to guide lateral, medial, anterior, posterior, and to find the correct position for Mitraclip implantation. Just a moment. Right here, we are below the valve into the left ventricle, and when the two leaflets are on the arms, then we lower the grips and do the grasping of the anterior and posterior leaflet, and then we check with 3D views if the bridging is good between the two leaflets, and we screen again the valve in order to see if we have a remaining mitral regurgitation.
Is Michael here? Harris? Comments, because you remember the case most than any of us.
Was certainly a two clip case so far as I remember.
Yeah, it's a two-clip case, and this was the first one.
Has a good tissue bridge and symmetrical orifices, and I think most of the jet was on the lateral side of things.
It was a jet from the lateral side. It was mostly seen from the ventricle side of the valve.
Yeah.
Here you can see this remaining MR.
Well, you'd like to leave the table with 0 MR as possible, unless you don't have a gradient, obviously. So we use this true view to see the leaflets in a different way. It's a new concept from Philips for anatomical imaging of the mitral valve. But in essence, there wasn't any, it was good leaflet insertion, and we decided to release this one and put a second device right next to it, laterally.
From our experience, when we have functional MR, we always try to have the best result because we don't want to see relapses after 6 months or 1 year in these patients. Here you can see we do the leaflet insertion. We go medial and lateral of the clip in order to see the length of the posterior leaflet we have into the clip.
Can advance a little bit to see the release of this device and the second device coming up. So here Andonis is releasing the clip. Can advance further.
And we have this MR from the lateral side of the clip. So we remove the lines and prepare the release of the clip.
And the way we remove the lines is the Francesco's way. We liked the way he told us. It's not the...
You can go ahead and proceed a little bit further to the release of the device. Okay.
The clip is released, it's stable at its position, and we check again the valve, see the bridging.
Interestingly, medial to the device, there is a deep indentation of the posterior leaflet that thankfully it wasn't deformed in any way, and we didn't see any MR from that spot. Here we have hemodynamics of the left atrium after the first device. And then...
The pressures didn't change much before the clip and after. And sometimes this is because of the fibrosis of the left atrium. We see much difference of the pressures in DMR and, of course, acute MR, and not always in functional MR, if you agree with that. So this was the remaining MR. We decided to proceed with a second clip, just lateral to the first. Here's the second clip coming out of the guide. Again, the same process, pull and flex. We don't want to touch any tissue, and of course we have to be careful not to touch the first clip, especially when we go through the valve into the left ventricle. Something that you all know is that when we put a second clip, we always put it with the arms closed.
Here we're checking for trajectory to see if we're not heading towards the lateral subvalvular apparatus. We want to be as parallel as possible to the first clip, so we won't have any deformation next to them. You can move a little bit further down and see the perpendicularity assessment. Okay, here we have, it's actually we have grasping of the A2, P2 there, lateral to the first device.
We always check perpendicularity when we put a second or a third clip. We want to be parallel and not distort the valve. And usually the second clipping is easier than the first one because leaflets are kind of immobilized. And we grasp the leaflets and see what's the remaining MR, the final result. And of course the mean gradient, we don't want to produce any mitral valve stenosis. We always check the mean gradient before releasing a second clip. And then here we had a very nice result with mild remaining MR, and we decided to release the second clip at its position. As you can see, we had a slight gap between the two clips, but this was very small. It was less than 5 millimeters, and many times with the fibrosis of the tissue over time, we see that this gap reduces, and we don't have any problem, especially in functional MR cases. In DMR cases with prolapse, we don't want any gap between the clips because of the movement of the leaflets. And this was the final result. It's considered to be a mild mitral regurgitation. Nice movement of the two clips, stable in their position. And then after the implantation, we check for a shunt at the atrial septum, see how big it is and if we need to do something. Of course, the surgeon's view in order to see the bridging, leaflet insertion, and all of that. Michael?
It was an acceptable result, so we left it at that. I think there is 3 orifices. There's one just between the devices, and there's a trivial jet of MR between the two. I'm not sure if we tried to bring them as close as possible. I'm sure we tried, and that was the best position that we could obtain. So
it's interesting that the next day in the transthoracic echocardiogram there was no MR. There is always some slight difference between transesophageal and transthoracic, and we always assess with the same blood pressure we begin.
You see pulmonary vein flow looks pretty good as well. Don't know if,
I don't know, because I stopped using echo as a primary decision making. I think you know, we had a very good. I mean, I'm a bit provocative here, but I think we should use more hemodynamics. You know, the Pascal system comes with a continuous LA pressure measurement feature. If you want to do it with Mitraclip, you have to add a catheter, which we do in all patients since 3 years. We are going now to publish our decision-making tree on almost 500 individual clips, not patients, clips. For each clip, we took a specific decision based on combination of echo guidance and pressure changes. And you know, it's very simple. These patients survive better with less pressures in the left atrium. They don't care about the color. I mean, the color doesn't make any symptom. What makes the symptoms is the pressure. So a good clip, independent good clip. So in a patient, you can have 1, 2, 3 clips. Every clip should improve because every clip creates a negotiation between less MR, more gradients. Every clip is reducing the orifice. So you need to really negotiate between increased gradients and less MR. And it's very simple. A good clip should have no color to please the echocardiographist, but this is the only objective. Should reduce the LA mean pressure and increase the LV pressure. If you have no improvement in LA pressure, you should question whether this clip is useful or not. It could be useful because it may stabilize, it may have a long-term consequence and so on. But I've seen number of patients where we have excellent MR, reduction by color Doppler. We have no gradient according to the rule that no more than 5 is okay. But then we have increased LA pressure. So we didn't implant the clip in those cases. So it's very important really to have a comprehensive assessment in these patients because in 10% of these cases, color Doppler could fool you. So what I see here, I think is good. It's missing the instantaneous measurement of LA pressure, which is my #1 guidance today. I have a fellow watching that during the clip. He's watching before and after clip what changes in terms of mean pressure in the left atrium, V wave, and LV pressure.
We don't do the measurement constantly with a Mitraclip because we don't put a second one, but we measure the mean pressure and the V wave after every clip. So what we saw here was a very slight improvement with the first clip and no significant change with the second. But like you said, it's important that if you see a deterioration, you should question your clip and probably remove it, change position. At least you shouldn't see deterioration, a rise in the mean pressure. And sometimes... Correct. So I think we conclude.
You need a separate puncture, actually, just from the